Hi, and welcome to the show. Subscribe at kevinimney.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Jay Joshi. He is a family physician. He's the author of Burden of Pain, A Physician's Journey Through the Opioid Epidemic. Today's Kevin MD article is titled, How Legal Liabilities and Skewed Decision-Making Plague Clinical Encounters. Jay, welcome back to the show.
Thank you for having me.
So, for those interested in hearing a story, just go back to your prior podcast, kevinmd.com/podcast, upper right-hand corner, search bar, click for Jay's name to hear his story. But today, let's go straight into your Kevin MD article, How Legal Liabilities and Skewed Decision-Making Plague Clinical Encounters. How did your article come together?
Really born out of experience and the insight gleaned from it, as you and I have discussed earlier. One of the things that many physicians struggle with is to make individual clinical decisions in light of the clinical data and the patient circumstances. We're very good at crafting clinical studies, aggregating data, and identifying best practices. But once we implement individual decisions from that plethora of data, we surprisingly become very non-clinical. And I postulate that in many ways we become influenced by some of the more adversarial aspects of healthcare, in which I specifically discuss the legal liability. And I think as physicians, we need to come to terms with how we make decisions and the influencing factors that lead to those decisions.
All right, so give us an example or a scenario that would really illustrate your point.
An example that probably has received majority of the evaluation and studies to date on implicit biases, and that would be in the emergency room settings. Many EDs often require physicians to make clinical decisions on the order of minutes. This requires snap judgments of patients, their clinical conditions, and then making decisions accordingly. Many of those decisions lead to disparities in outcome, and we've seen race-based disparities, gender-based disparities. Now, to reconcile that, one potential argument, which I completely do not agree with, would be to say that, well, there must be discriminatory practices among physicians. I think that's completely untrue, but it's hard to argue with the outcomes that have been shown. A better, more meaningful rationale would be to say there are implicit biases that are affecting individual decisions. How do we tease out those individual decisions so we can get to the point where individual decisions meet the clinical rigor that we expect of clinical studies? And so, what I do in my paper is I create a framework known in game theory. Now, when I use the word game theory, for those not familiar, it has nothing to do with the game and finds nothing humorous in biases in clinical decision making. It's simply an economic principle that analyzes how decisions are made based upon rules and frameworks set around those decisions. And what I specifically focus on is my own personal experiences, and that's making decisions on prescribing opioids for chronic pain in the outpatient primary care setting. What I identify are certain factors that would drive clinical decisions, the decision to prescribe, the decision not to prescribe. Now, many of those decisions lead to consequences that are distinctly non clinical: legal liability, DEA investigation, insurance audits. These factors weigh in on the minds of physicians, whether people would like to admit that or not. And what I wanted to do is tease out those implicit biases and define them explicitly in the payoff structure that determines how decisions are made. And in many ways, it shows how principles of harm reduction and curbing legal liability to physicians can actually lead to more clinically meaningful decisions. It's essentially saying that if you limit the downside risk of a bad decision or a decision that may not be in full concordance with what you believe, then you enable more clinically accurate decisions. And I think that's something we implicitly understand, kind of, pun intended, if you will. But I think that we're just so ingrained in the healthcare system of malpractice suits, of legal liability, that we think. I wanted to really raise awareness on the importance of individual decision making.
So you mentioned some of these external factors that influence decisions, and you specifically mentioned legal liability. So how does the threat of a malpractice lawsuit or the threat of liability, how does that specifically influence physician decision making?
Generally speaking, creates a certain tendency towards standardization. So it homogenizes decisions right off the bat. And for many, that may seem like a good thing, right? We want to have evidence-based medicine following a standard of care. So many would think that, yeah, we would need something like that because we want to create certain parameters around the clinical decision making. The problem lies, though, when you create artificial homogeneity around decisions that are inherently uncertain. And that's when you start to get into the unintended consequences, because now you're making decisions that impose a certain conformity when in reality, individual patient considerations should be given. And I think that's the balance that we're struggling to find. And so when you look at patients with chronic pain who require prescription opioids, we've stigmatized opioids so much that we've actually eliminated the medication from its clinical context. So instead of looking at the patient with a clinical condition requiring certain medication, it's a person asking for certain medications. We've devoided that entire context of its clinical principles. And by doing so, we enable other non-clinical factors to influence our decision making. And so that's when the legal liability component starts to become an issue because it takes away some of those individual clinical considerations. So it's one of those things where just enough legal liability is good, too much produces the opposite effect. And so by using concepts like game theory and other behavioral economic principles, you can start to tease out the relative effects of legal considerations, of clinical considerations, to then see how are we guiding, or more bluntly, how are we influencing clinical decisions? And is it in the patient's benefit the way we're influencing decisions?
Now, for those who do not have a background in game theory or behavioral economics, give us a scenario or example of how this will play out in a real life scenario.
Sure. I'll start with the most common example that's used as an introduction. That would be the prisoner's dilemma. And just real quickly, it's a scenario where two individuals are apprehended by the police and put in separate jail cells. And they are apprehended for the alleged crime of kidnapping a car. They're put into separate jail cells. Each of them are told that if they rat on the other individual, they will have a very mild sentence and released. But if they say nothing, they'll have a very severe sentence. Now, neither of the individuals may have committed any crime or whatnot, but it would be in both individuals' best interest not to say anything if they were to work together. But if there's no trust and they're turning against one another, it would be in their best interest to effectively rat on each other. So it's a clinical example. It's a clear example in which you see how the individual incentives differ from the group dynamics, and that both of those individuals clearly should just stay quiet and stick together. But they're in separate jail cells. They're not sure what the other person is thinking. So they act in their against their best interest because they don't know how the other individual is acting. That, the long and short of it, can be a basis for how to understand game theory, and that you're looking at individual incentives alongside group dynamics.
All right. So you gave the example of prescribing opioid medications and implicit biases in the emergency department. Any other common primary care scenarios where game theory, behavioral economics can help remove some of these externalities in the decision making process?
It can be applied in so many contexts because it's a framework for thinking. So you can apply that framework for thinking for many conditions. Let's talk about hypertension. Let's
Hmm.
talk about obesity. If you have a patient who comes in with uncontrolled hypertension, their systolic remains above 150, 155, start them on one course of medications. You start them on diuretic, then kind of move to an ACE. You are effectively making judgments on the decisions based upon the blood pressure readings. You're assuming the patient is compliant with the medications as prescribed, or at least understands when and how to take it, or at least understands what type of diets to maintain. All of these are assumptions that you make. Another word for assumption is bias. Now, if you were to look at, let's say, a Caucasian affluent male, seems to be well composed, on top of his game, professionally successful, you may, as a physician, be more inclined to believe he is more compliant with when taking the medication and his diet. And you may be more inclined to say, oh, well, your blood pressure is still not well controlled. Let me add another medication. Now, let's say you're dealing with, an impoverished Asian female from, Northern California and looks disheveled, doesn't present herself in the best manner, you may tend to think more along the lines of non-compliance. So you may think, well, you know what? Let's just keep your blood pressure medications as they are. Let's focus on behavioral changes. Let's focus on diet. Let's focus on compliance with your medications. So the method by which you focus on caring for the patient in that encounter is a direct result of the implicit biases that percolate on top of creating a dominant perception. That dominant perception then leads to the clinical care you provide. And so I use that example to show how all the factors go into treating a patient with hypertension, but what factors you choose to emphasize depend on the biases you choose to acknowledge at the time of the encounter.
Now, tell us for those clinicians or medical trainees, how can they start this? What's the first step in terms of recognizing these biases and removing their influences from decision making? How can they first start?
Well, I think it starts by recognizing how you learn about medicine. One of the key things we always focus on is the differential diagnosis. You take together a constellation of symptoms and signs, piece together information that is known and what is not known, and then you create a list of differential diagnoses that could be the pertinent condition. Part and parcel to every third year medical student's experience throughout residency and onward. What we learn over time are shortcuts to this. For example, a patient presenting with right lower quadrant pain, vomiting, emesis, and elevated WBC, a fever, elevated temperature. These are diagnostic for appendicitis, and it's almost reflexive. One of the things we don't realize about that type of thinking is that it's predisposing us to biases, right? Those heuristics, those thought patterns that we create to simplify clinical decision making are also the sources of the biases. So it's one of those things, just like with legal liability. Some of it is good, a lot of it happens to be bad. Same thing with clinical decision making and use of heuristics. Some of it is good, some of it is downright necessary. No physician is going to realistically say they're going to create a differential diagnosis for all 20, 30, 40, 50 patients that they see in a given time interval. Some of it requires reflexive thinking. But the moment you start to impose too much of that and not be aware of when there's limitations in using those heuristics, that's when you start to make clinical decisions that require a little bit more diligence, require a little bit more than just the reflexive thought pattern. So, as physicians and trainees, medical students, residents, one of the things I would really emphasize is the confidence in the assumptions made in decisions. The confidence in the assumptions made in decisions. Healthcare, by nature, contains an inherent amount of uncertainty. That's fundamental. The question then becomes how much of that uncertainty is acceptable to gloss over with a heuristic, and how much of that uncertainty needs to be addressed and given additional consideration. As you go through your medical training, as you start to learn the fundamentals, recognize when and how uncertainty plays its role.
So, in general, do you feel that the pendulum has swung too far towards heuristics and biases? And are you looking to swing that pendulum back more towards the middle?
I understand the analogy of a pendulum in the sense that it's a binomial construct where using these are good, not using them are bad, so to speak. Let me maybe dance around that question and then kind of address it head on. I think the moment we started to implement scientific methods into medicine, and then in the 90s start to incorporate evidence-based medicine, we started going towards heuristics and biases because ultimately the scientific method creates modes of thinking by taking uncertainty and providing facts and theories around it, and then you build upon that. So you can't advance your knowledge in any scientific endeavor without building upon the assumptions that were made. Done wonders in medicine, chemotherapy, radiation, surgeries, procedures. The use of science has done wonders. The issue, however, which I think has been made quite apparent in the pandemic, is that there's a limit to how far this can go. And the pandemic made very apparent that patient trust, patient autonomy are rate limiting factors to the advancement of science in healthcare and to the use of evidence-based medicine. And by that logic, the use of heuristics. We had vaccines in record time. We couldn't get patients to take them in some parts of this country. The reason for that was a trust factor. There's nothing scientific about quantifying trust. It's something implicit and inherent. So I think the pendulum analogy is good in the sense that we're trying to create a balance between all of those. But I would argue that futurists, people who make predictions about the future, always caution against looking at the future linearly or appearing rationally. I would contend that the future of healthcare really requires on this amorphous blend of understanding how we think the strengths in thinking on evidence-based medicine using heuristics, and understanding how uncertainty fills the void around that. The analogy I use, and I write about that in Burden of Pain, is I talk about the atom. So you have the nucleus. For the longest time, we focused on the protons and the neutrons and just assumed the electrons were just revolving around, almost like a planetary model of the sun and planets. Now we know that the electrons themselves are not actual particles, but orbitals, and that their characteristics actually define the atom more than the nucleus itself. In that same vein, I would contend that science has a role. Evidence-based medicine heuristics are essential factors as we increase the use of technology in healthcare. But we can't forget that it's the uncertainty surrounding all of that that really influence healthcare, because that's the factors that drive patient behavior.
We're talking to Jay Joshi. He's a family physician. He's the author of Burden of Pain, A Physician's Journey Through the Opioid Epidemic. His Kevin MD article is titled How Legal Liabilities and Skewed Decision-Making Plague Clinical Encounters. Jay, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
The first thing I would like to leave with the audience is to just be aware of how you make decisions, because awareness is the biggest factor in improving overall clinical decisions. The second thing I would say to the Kevin and D audience is continue to challenge the paradigm of thinking in clinical medicine by pushing for innovative models. Let's incorporate behavioral economics. Let's incorporate non-scientific methods of thinking and learning into medicine, because as we all know in medical school and quickly forget thereafter, medicine is both a science and an art.
Jay, thanks for coming back on the show and sharing your time and insight.
Thank you, sir.